Hi, good afternoon. My name is Ikram Habarbian. I'm from ITB and I'm from Indonesia, and this is my group.
My name is Alifa. I'm from Indonesia and I'm also from ITB.
My name is Jessica. I'm from Indonesia. I'm also from ITB.
My name is Maisara and I'm from Malaysia.
My name is Alet and I'm from Egypt.
So today we're going to extrapolate on the monograph of our drug, which is Besponsa, which is a drug just recently released by Pfizer. Hope you enjoy.
So I'm going to talk about the background of the drug and also the background of a disease that actually being cured by Besponsa. So Besponsa is the brand name of the inotuzumab ozogamicin. That is an IDC composed of CD22 that is commonly linked to N-acetyl gamma caliciamycin dimethylhydrase. And inotuzumab is the humanized immunoglobulin class G, subtype 4, which is called AGG4 antibody that is specifically designed to recognize CD22 on human body. And the small molecule, which is the acetyl gamma caliciamycin, is a cytotoxic product. So here I'm going to talk more about leukemia, which is the disease that is being cured by Besponsa. So leukemia has a type which is acute and chronic. The acute is more dangerous. That's why it should be treated more fast than the chronic, because chronic progress more slowly. And there is classification for the leukemia based on their phenotype, which is the lymphocytic and myelogenous. Lymphocytic, there is acute lymphocytic leukemia and the chronic lymphocytic leukemia, while the myelogenous have acute myelogenous leukemia and chronic myelogenous leukemia. So Besponsa is used for the ALL. ALL is often occur on children because it attacks on the immune system that is consists of B cells and T cells. And lymphocytic, why it's like being divided into two, why lymphocytic and myelogenous, because the red bone marrow that is being attacked, because the white blood cell is actually like being mutated. The abnormal white blood cells will actually become lymphocytes. That's why it's lymphocytic. While for the myelogenous, the abnormal white blood cells will become the red blood cells, white blood cells, and also platelets.
So now I'll explain about the mechanism of action. So at first, can I call out the 4 people who helped us practice this morning to be involved in the mechanism for the MOA? The 4 people.
Sorry.
Okay, so at first I'm going to introduce the role. This person wearing the halo will be the Besponsa, which is This person is the monoclonal antibody. It is the best sponsor. And then the person wearing the crown is the N-acetyl-gamma-calicamycin, which is the cytotoxic agent. So she will be the hero for this event. So as you can see, we form a circle. This is the B cell itself, and this paper is the DNA strand. And then the person wearing the cone is the CD22, which is the cell surface antigen, which is expressed on the B cell. So at first,
Make the CD22 a little bit. Yes, we need to make a copy.
So for information, Besponsa is an antibody drug conjugate which is composed of a monoclonal antibody. So she is the monoclonal antibody, and she is linked with the N-acetyl-gamma-calicamycin, which is the cytotoxic agent. So this ADC will be attracted to the CD22. Okay. So when they are linked, they will form an ADC CD22 complex, and then this complex will be internalized into the B cell. So they will go inside the B cell. And then when they go into the B cell, this cytotoxic agent will be released from the ADC, and then she will be activated. So after the activation, she will break the DNA double strand inside the B cell. Okay. After the DNA strand breaks, so this B cell will undergo apoptosis. So that's the story now. It's very simple. So right now we will show you a video for further explanation about the mechanism of action.
www.isaac.com for important treatment considerations related to inotuzumab ozogamicin, including box warnings, contraindications, and additional safety information. In 2017, 5,970 new cases of acute lymphoblastic leukemia were diagnosed in the United States, with an estimated 1,440 deaths. The 5-year survival rate for ALL is approximately 68%, based on SEER data from 2007 to 2013. However, 5-year survival rates in studies of patients with relapsed ALL are 10% or less. ALL is characterized by the presence of abnormal lymphocytic blasts in the bone marrow. CD22 is a receptor expressed on the surface of normal and malignant B cells, but not hematopoietic stem cells. CD22 is involved in B cell receptor, or BCR signaling, and BCR-induced cell death, modulation of humoral immunity, and malignant B cell growth. CD22 is expressed in greater than 90% of B cell ALL cases. Increased expression of CD22 was observed from pre-B to mature B cell stages. Inotuzumab ozogamicin is an antibody drug conjugate directed against the CD22 antigen. Inotuzumab ozogamicin consists of an anti-CD22 monoclonal antibody covalently linked via an acid-labile butanoic acid linker to the cytotoxic antibiotic N-acetyl-gamma-calicamycin dimethylhydrazide. The first step in the mechanism of action of inotuzumab ozogamicin is binding of the monoclonal antibody portion to the CD22 antigen receptor on the cell surface. Once bound, the inotuzumab ozogamicin CD22 complex is rapidly internalized into endosomes that subsequently merge with the lysosomal compartment. The low pH of the lysosome hydrolyzes the butanoic acid linker, releasing calicamycin. Release of unconjugated calicamycin in the serum has been shown to be undetectable following administration of inotuzumab ozogamicin. Cell surface CD22 is then rapidly internalized. However, in vitro studies demonstrate no loss of CD22 expression after treatment with inotuzumab ozogamicin. Maintenance of expression of target surface antigen is important for clinical efficacy of many drugs, and indeed, loss of receptor expression and shedding are important potential mechanisms of drug resistance. Negligible levels of soluble CD22 were detected in the peripheral blood and bone marrow supernatants, suggesting that CD22 is not shed after binding inotuzumab ozogamicin. Calicheamycin diffuses to the nucleus, binds the minor groove, and causes double-stranded breaks, cell cycle arrest, and leukemia cell death via apoptosis. Inotuzumab ozogamicin is a humanized anti-CD22 monoclonal antibody covalently linked via an acid-labile butanoic acid linker to the cytotoxic antibiotic calicheamycin. CD22 is highly expressed in B-cell ALL, and CD22 expression on B cells is observed at multiple stages in cell life, from pre-B to mature B cells. The inotuzumab ozogamicin CD22 complex is internalized and merges with the lysosomal compartment. The acid-labile linker is hydrolyzed, releasing calicheamycin to diffuse to the nucleus. Calicheamycin binds the minor groove of the DNA and causes double-stranded breaks, cell cycle arrest, and cell death via apoptosis, with undetectable systemic release of unconjugated calicheamycin. To access our full scientific response document on the mechanism of action for Besponsa, you can visit www.pfizermedicalinformation.com, or you can call Pfizer Medical Information at 1-800-438-1985. To view the Besponsa prescribing information, you can visit www.pfizermedicalinformation.com/en-us/Besponsa. This presentation gives.
And the first reaction of the Besponsa is like infection, inflammation. As you can see in the slide, is immunity disorder, gastrointestinal disorder, etc. And for the dosage and administration, is can use by intravenous with the starting dose is 0.8 milligram per meter square and 1.8 milligram per meter square, which is should divided into 3. In the day 1 is 0.8 milligram per meter square, and day 8 is 0.5 milligram per meter square, and in the day 15 is 0.5 milligram per meter square. And for the availability, the Besponsa has been approved by European Committee in June 2017 and approved by FDA in August 2017 and by the National Institute of Health and Care Excellence, NICE, Committee textbook and the evidence for the drug at January 2015. Because the NICE has not found the benefit from Besponsa better than current treatment. For the monitoring for the patient who consume the Besponsa, should do the liver test as LT, IST, total bilirubin, and alkali phosphatase. And for the patient who consume the Besponsa and found the liver test is not good, should be treated more frequently. And the treatment should be permanently discontinued if it found VOD and SOS.
So I'm going to talk about contraindications. First of all, like we said before, Besponsa causes hepatotoxicity, and that's why it can be used with patients who have experienced prior or ongoing veno-occlusive liver disease or sinusoidal obstructive syndrome. Also with the patient with serious ongoing hepatic disorders like hepatitis, active hepatitis, and cirrhosis, and nodular regenerative hyperplasia. And like all drugs, if there is hypersensitivity to the active substance, it can be used. The pharmacokinetic properties. First of all, like she said, patients who are treated with inotuzumab ozogamicin, the starting dose is 1.8 milligram per meter cube per cycle, and the steady state concentration is reached by cycle number 4. That means like 7.2 milligram. The distribution, the binding of the N-acetyl gamma chalichomycin dimethyl hydrazide to human plasma proteins is like 97%, and the total volume of distribution is 12 liter. The metabolism, the N-acetyl gamma calicomycin is metabolized via non-enzymatic reduction. The elimination was well characterized by a two-compartment model with linear and time-dependent clearance component. Two-compartment model in pharmacokinetics, it's like the first compartment is the central one, where drug distribution is instant, and the second compartment is the peripheral one, where drug distribution is slower. In 234 patients, the clearance at steady state was 0.0333 liter per hour. Based on population pharmacokinetic analysis, the age, race, and gender didn't affect the drug deposition. Drug interaction. In patients receiving inotuzumab, prolonged QT interval was observed, and that's why if there is other drugs that prolong it or cause torsade de pointe, like amiodarone, quinidine, and procainamide, it should be carefully considered first.
Okay, so the FDA approved the drug to be released to the market once a phase 3 study was released on 2017, which was followed by another approval by the European Medical Commission and thus by the European Union by 2017. So far, if you see in clinicaltrials.gov, there are 12 completed studies, on which 8 are phase 1 studies, 5 phase 2 studies, and there's of course only 1 phase 3 study. Now, the numbers might not match up to 12 because, as you probably know, phase 1 studies and phase 2 studies recently there has been studies which combine phase 1 and phase 2 studies for efficacy of the study and also to match up the dose going from phase 1 to phase 2 better. And here we are presenting one phase 1/2 study and another phase 3 study. The first one would be a phase 1/2 study, which was conducted by Pfizer and published in January 2016. All of the studies here are oral, by which they're open label, in which there's no such masking or double blinding whatsoever. The phase 1/2 study is non-randomized, in which 0.8 to 2 milligram per meter squared is administered intravenously on every 2-3 times a week for 24 weeks. The phase 1 part was meant to evaluate the safety, tolerability, and efficacy of Besponsa for treatment of ALL at increasing doses, in which the point is to find the dose-limiting toxicity. And then the phase 2 part is to evaluate the efficacy in terms of hematologic remission, which is measured by complete remission. It's tested on 72 patients, in which the inclusion criteria would be patients suffering ALL, which are CD22 positive, with the Philadelphia chromosome positive, and they failed standard treatment of at least 1 TKI, and of course adequate renal function and hepatic function, and negative pregnancy test. It excludes those with isolated extramedullary relapse or active CNS leukemia, prior allogeneic hematopoietic stem cell treatment or other anti-CD22 immunotherapy within the range of 4 months, or active graft versus host disease, and evidence of history of VOD or SOS as mentioned in the monitoring previously. The primary outcomes here are the measurement of percentage of participants reporting DLT, dose-limiting toxicity, and also percentage of participants with preliminary satisfactory result, in which these are the results. And we can see that the DLT only hits at the highest dose, in which previously it's measured as 0%, and there is also lowering the satisfactory result. And then the phase 3 studies. If you Google this there's a fact sheet regarding the drug. It's also known as the Innovate. It's a set of randomized trials. It's all in which it's open label, multi-centered, in which it's conducted in multiple clinics. International, it was held in a number of countries, anywhere from Australia, Singapore, go all around Europe and US. And it's also parallel assigned, in which it differs than your crossover study. That would be the dosing, and then it measures for safety and efficacy of Beswanza for the treatment of ALL in comparison to the chosen 3 other chemotherapies. The number of patients here are much larger, in which there are 327 respondents included, and includes those patients aged 18 years old and older with CD22 expression and adequate liver function and renal function. And it excludes people with isolated extramedullary disease and other active CNS disease. The primary outcome and secondary outcome here are the primary being percentage of participants showing hematologic remission, and also overall survival measured around 5 years or 2 years from the last participant. And then the secondary outcome would be percentage of participants showing HSCT and MRD negativity. MRD negativity being residues of the disease left over after complete remission is measured. And then we can see that by measure of complete remission, the treatment with Besponsa is much better than the standard chemo, about more than 50%. And also with the MRD negativity, in which complete remission is more validated, you can see it's also 50% higher. Also with the possibility with HSCT, because we want to treat the patients with hematopoietic stem cell treatment, the acceptance rate is much better, and then the median overall survival for usage of Besponsa is about a month longer than your standard chemotherapy. So it shows in this phase 3 that it's not only that it excels in inferiority trials, but also in superiority in the sense that it is better than the chosen 3 chemotherapies. And these are our references.
Why there is an interval like until 1 week gap? Can you explain about that?
We're discussing about the answer. Do you have any other questions regarding other topics? Maybe you can ask them. No? Any questions?
Anybody want to answer that instead?
Let me try. Like, in a sense, right, you guys have clinical trials, right? And in these 3, they were given 3 dosing, was it? Okay, so basically whenever you actually have a dosing, whenever you have a dosing, in a sense, whenever you want to give patients dosing, you actually have to try out the dosing itself. So sometimes you have to trial and error the amount of dosing they can give. So the reason why they choose that particular dosing, because they tried out clinical trial and it works, that's why they apply it in real life. Usually sometimes it depends on the half-life, sometimes it depends on the response of the patient, sometimes it depends on the preclinical. So in this case, it's mostly you look at the clinical trial result it has shown, then you take it in. That's what I would answer generally, because when you look at half-life, it really is dependent on how the patient reacts towards it.
But also remember, this is a chemo drug. It's a chemo drug.
Yes.
You cannot have it every day. You will die.
Yes.
Okay?
Yes.
So you need to have a certain cycle. Yes. So they have, you guys should know it.
They have it.
21 days, so day 1, day 8, day 15, and then by the 21 days, back to day 1 again. Every time chemo drugs is important to know. Okay? All right. So, any other question? Okay, then the second person, please.